So here's something I see play out in my clinic almost every single week. A patient comes in. They've noticed blood when they go to the bathroom. Maybe on the toilet paper, maybe in the bowl. And they've been sitting on it for weeks, sometimes months, treating it like they're unread emails, just hoping it goes away if they don't look at it directly. And I get that. I get that completely. But here's the thing. That delay, that period between noticing blood and actually doing something about it, that is the window that matters most. And in colorectal disease, that window is everything. I'm Dr. Matthew Glover. I'm a board-certified gastroenterologist practicing in Las Vegas. I do thousands of colonoscopies every year, and I see hundreds of patients every month. Rectal bleeding is one of the top 3 reasons patients come to see me in clinic. I see patients every day who are scared of what that blood may mean. And the very first thing I want to tell you, before we get into anything else, is this. Most people who see rectal bleeding are not dealing with cancer. I want to emphasize that because I know how our brains work when we see blood. The overwhelming majority of people who come in to see me with rectal bleeding have something completely benign going on, something treatable, something that, once we figure out what it is, has a very clear path forward. But, and that is a significant but, that does not make it something to ignore. Because the cases that do need attention, the cases where catching it early changes outcomes and saves lives, those cases only get caught if the rectal bleeding is not ignored. And people who keep convincing themselves it's probably fine, who wait another month to go see if it goes away, who quietly hope they don't have to deal with it, those are the people who sometimes end up sitting across from me with a diagnosis that would have looked very different 6 months ago. And this is why understanding and differentiating rectal bleeding is so important. Colorectal cancer kills around 50,000 Americans every year. It is the 3rd most common cancer in the United States. And here's the number that I want you to hold on to. When we catch it at its earliest stage, stage 1, the 5-year survival rate is over 90%. When it's caught late, at stage 4, that number drops to somewhere around 15%. That is not a gap in treatment. That is a gap in diagnosis and timing. So that's what today's video is about. I'm going to walk you through everything you actually need to know about rectal bleeding, what the different presentations mean, what the causes are, what the specific red flags that tell me as a gastroenterologist that this needs to be looked at urgently. And I'm also going to talk about something that I see happen over and over again in my practice. A pattern that causes people to be repeatedly assured when they shouldn't be. And that may delay the diagnosis of something serious by a year or more. I'll come back to that, so stay with me on that one. And if you're new here, welcome. I put out practical gut health content on this channel based on what I see every day in clinical practice. If that's something you want more of, or you find benefit from these videos, hit subscribe and like the video. I don't want you to miss something that may have major implications for your health. And subscribing helps others who may benefit from this information find these videos. All right, let's get into it. The first thing I want to cover, and this is something I walk through with almost every patient who comes in with rectal bleeding, is what the appearance of the blood actually tells you. Because not all rectal bleeding looks the same. And the color, the location, the timing, all of that gives us important clinical clues before we've even run a single test. Now, most people describe bright red blood on the toilet paper when they wipe, in the bowl after passing a stool, maybe coating the outside of the stool itself. And that bright red color is actually telling you something useful. It means the blood is fresh. It hasn't traveled far. It's coming from somewhere lower in the gastrointestinal tract. The rectum, the anal canal, that general area. And the most common causes of that kind of bleeding, hemorrhoids, anal fissures, they live right in that zone. So bright red blood in isolation with no other symptoms is often the most reassuring presentation that I see. Darker blood is a different picture. Blood that looks maroon, blood that seems to be mixed into the stool rather than just sitting on the surface, blood that gives the stool a dark or almost burgundy appearance, that tells you the bleeding source is typically higher up, more proximal in the colon or intestines. Because the further blood travels through the gut, the more time hemoglobin has to partially break down and change color. And that shift from bright red to darker is one of the things that increases my index of concern. And then there's something called melena, black, tarry, sticky stool. This gets my attention immediately. If you've ever smelled melena, you don't forget it. Melena has a very unique smell, and I will spare you the specifics, but if you've ever opened a trash can that has been sitting in the sun for 3 days, you're somewhere in the right neighborhood. That presentation typically means significant upper gastrointestinal bleeding. We're talking stomach, esophagus, small bowel. That is a call an ambulance situation. That is not rectal bleeding in the typical sense, and it is not a wait and see scenario. But for most people watching this, we're talking about bright red blood. So let's talk about where it actually comes from. I want to go through the causes, and I want to be deliberate about the order here, because I think it matters. I don't want to lead with cancer and have everyone spiral. The most common causes of rectal bleeding are benign, so that's where we'll start. Number 1, hemorrhoids. I have had this conversation more times than I can count. Hemorrhoids are swollen, engorged veins in the rectum and anal canal. And here's the thing. Everyone has the vascular tissue that can become hemorrhoids. Every single person. It's just part of the anatomy. The question is whether that tissue becomes symptomatic. And for a lot of people, it does. 3/4 of adults will develop symptomatic hemorrhoids at some point, which means this is not a rare, embarrassing condition that happens to other people. This is basically a normal part of being a human with a colon. Now, hemorrhoids can be internal, sitting up inside the rectum, where you often cannot feel them at all, or external, around the opening, where they can be visible and often quite painful. Internal hemorrhoids are probably the most common cause of bright red rectal bleeding that I see, and the bleeding can look dramatic. People come in describing the toilet bowl looking like a deleted scene from a true crime documentary. A significant amount of blood. And then I examine them, and there are 2 internal hemorrhoids sitting right there that have been bleeding. We ban them, we talk about dietary changes, fiber, proper hydration, and the problem resolves. Now, the reason I want to spend some time on hemorrhoids is not just because they're common. It's because they're so common that they become a convenient explanation for patients and for doctors. Oh, it's probably just hemorrhoids. But sometimes that's the diagnosis that gets applied when no one has actually looked inside to make sure that's the whole story. I'll come back to this. Number 2, anal fissures. These come with a very specific symptom pattern. A fissure is a small tear in the lining of the anal canal. And the pain is what defines it. Sharp, tearing, burning pain during a bowel movement, and often for sometimes afterwards. The kind of pain that makes people dread going to the toilet entirely. And then, bright red blood, on the paper, in the bowl. Fissures usually happen because something hard or large passes through the anal canal and creates a tear. Constipation is the classic culprit. Hard stools, straining, sometimes persistent diarrhea. They can occur of childbirth as well. And most acute anal fissures will heal on their own with the right management. We're talking about fiber, stool softeners, keeping the area hydrated, topical treatments to relax the sphincter muscle. Chronic fissures that have been there for a long time sometimes need more intervention, including injections or a minor procedure, but they also respond well to treatment. Number 3, diverticular disease. This one is less talked about, but is actually a very common cause of rectal bleeding. And when it bleeds, it can bleed a lot. Diverticulosis is the condition where small pouches, called diverticula, form in the wall of the colon. It's extremely common, especially as people get older. A large portion of adults over 60 have at least some degree of diverticulosis. Most of the time, these pouches cause no problems at all. But occasionally, a small blood vessel running inside one of these pouches ruptures, and it can cause a significant bleed. Usually painless, sudden, large volume, bright red or maroon blood. Most diverticular bleeds stop on their own, but they need to be properly evaluated and monitored. And in some cases, they do require intervention. If you haven't already, check out my videos on the channel about diverticulosis, diverticulitis, and diverticular bleeding. Number 4, Inflammatory bowel disease. IBD, Crohn's disease, and ulcerative colitis affect somewhere around 3 million Americans. And rectal bleeding is one of the defining features of both conditions, particularly ulcerative colitis. Ulcerative colitis causes inflammation and ulceration of the lining of the colon and rectum, and that inflamed, damaged lining bleeds. People with active ulcerative colitis can have significant amounts of blood with every bowel movement, often multiple times a day, often with urgency, mixed with mucus. It significantly affects quality of life and is something that requires a proper diagnosis and an ongoing management plan, not just reassurance that it's probably hemorrhoids. Crohn's disease can also cause bleeding, though it depends a lot on where in the gastrointestinal tract the disease is most active. Colonic Crohn's will cause visible blood, whereas more proximal disease in the small intestine may cause occult bleeding, blood you cannot see that only shows up on testing. The point with IBD is this: if someone is having recurrent significant rectal bleeding alongside urgency, mucus, weight loss, or abdominal cramping, IBD absolutely needs to be under consideration. And it's a diagnosis that sometimes takes longer than it should to reach because the symptoms get attributed to IBS or stress or diet before anyone actually looks. Number 5, polyps. And this one is particularly important from a prevention standpoint. A polyp is an abnormal growth on the lining of the colon or rectum. Most polyps are completely benign. They sit there, cause no symptoms, cause no problems. But a specific type of polyp, adenomas, have the potential to become cancerous over time. That progression from a benign polyp to a colorectal cancer takes years, usually somewhere between 5 and 15 years. And that long window is exactly the reason colonoscopy screening is so effective. We find the polyp, we remove it on the spot, and we've just intercepted the process before it had a chance to progress. You can check out the many videos on my channel about the polyp to colorectal cancer progression pathway and colonoscopy. Now, larger polyps can bleed, and the bleeding is often intermittent. Sometimes it's there, sometimes it isn't. And that pattern of intermittent bleeding, a few episodes of blood, then nothing for a few weeks, then a bit more, gives people false reassurance. They think, well, it stopped, so I must be fine. And look, I say this with love. That is genuinely delusional thinking. No cap. Intermittent bleeding from a polyp is still bleeding from a polyp, and a bleeding polyp needs to be found and dealt with. Number 6, colorectal cancer. We've arrived here, and I wanted to put this in its proper context. Colorectal cancer is not the most common cause of rectal bleeding, not even close. The most common cause is hemorrhoids, by a significant margin, but it is the cause we cannot afford to miss, and it is the one where certain patterns of symptoms need to make us act, not wait. Colorectal cancers can bleed directly. A tumor bleeds into the gut, or they can bleed intermittently, which is one of the reasons people dismiss early symptoms. And they can bleed in a way you can't even see. Slow, chronic, microscopic bleeding that doesn't show up in the toilet, but that over weeks to months can deplete your iron stores and show up on a blood test as iron deficiency anemia. That last one catches a lot of people by surprise. So let's talk about the red flags. This is the clinical framework I use. The things that when I hear them, move the conversation from let's monitor this to we need to act now. Red flag number 1, any rectal bleeding in someone over 45 who has never had a colonoscopy. Full stop. If you are over 45 and you have new rectal bleeding and you have never had a colonoscopy, you need a colonoscopy. The American Cancer Society moved the colorectal cancer screening age down from 50 to 45 precisely because we are seeing an increase in this cancer in younger and younger people. The data moved the guidelines. And if you're in that age bracket and you haven't been scoped, this symptom is your indication. Red flag number 2, blood that is mixed into or through the stool, not just on the surface. Blood that coats the outside of the stool or appears after it has passed tends to point towards a lower anal rectal source. Blood that appears incorporated into the stool, that darker maroon presentation mixed throughout, suggests something higher up into the colon. That pattern warrants evaluation. Red flag number 3, rectal bleeding combined with a change in bowel habits. This combination is clinically significant. If you are noticing blood and at the same time your bowel pattern has shifted, stools that are narrower than they used to be, a change in stool caliber, going more frequently, persistent diarrhea or constipation, that's new for you, feeling like you cannot fully empty, a sense of incomplete evacuation, that combination raises my level of concern considerably. A tumor in the colon changes the anatomy of the colon, and when the anatomy changes, the function changes with it. Red flag number 4, rectal bleeding with unexplained weight loss. Weight loss you are not trying to achieve, without a dietary change, without an explanation. And before anyone in the comments says Ozempic, no, that doesn't count. Medically supervised weight loss is accounted for. I mean unexplained, without a reason, that in combination with rectal bleeding needs prompt evaluation. These two together are a classic presentation for GI malignancy. Red flag number 5, rectal bleeding with abdominal pain that is new and progressive. Not the typical fluctuating discomfort of IBS, not the cramps that come with a bowel movement and then resolve. We're talking about new, persistent, progressive lower abdominal pain alongside rectal bleeding. That needs to be looked at. Check out my specific video about IBS versus colon cancer for more information about how to differentiate IBS versus colorectal cancer. Red flag number 6, iron deficiency anemia on a blood test, even without visible bleeding. This one surprises a lot of people. They haven't seen any blood. They may feel tired, may be short of breath, may be a bit pale. They've just been exhausted, running on fumes, low energy, and assuming that's just life. They get a routine blood test and their hemoglobin is low, as is their ferritin. Their iron stores have been depleted. And the assumption is that they just need to eat more iron. And that's sometimes the whole story. But in a man or a woman where there is no clear physiologic explanation to be losing iron, unexplained iron deficiency anemia is a gastrointestinal bleed until proven otherwise. There is a slow, chronic, invisible leak, a source of blood loss somewhere in the gut, and it is my job to find it. Remember, iron deficiency anemia is not a diagnosis. We need to find out why, and taking iron supplementation is just a band-aid, not addressing the root cause. Red flag number 7, a significant family history of colorectal cancer or polyps. If you have a first-degree relative, meaning a parent, sibling, or child, who was diagnosed with colorectal cancer, your personal risk is roughly doubled, and the screening age shifts. If they were diagnosed at 60, we typically start screening at 50, and if they were diagnosed at 50, we start at 40, 10 years before the age of diagnosis. That's not optional guidance, that is evidence-based clinical practice, and it's something I talk about with my patients constantly, because people often don't realize that their family history fundamentally changes the picture. And keep in mind that a family history of polyps is often considered a colorectal cancer equivalent. Now, let me tell you about that pattern I mentioned at the start of the video, because this is something I see repeatedly in my practice, and I think it's one of the most important things I can say in this video. It goes something like this. Someone notices blood when they go to the bathroom. They go to their doctor, the doctor does an external exam, or maybe even a digital rectal exam. Everything seems consistent with hemorrhoids. The doctor says, "This looks like hemorrhoids, let's just watch it." The patient goes home, and the bleeding continues to come and go. Sometimes it's there, sometimes it isn't. They continue to attribute it to hemorrhoids. A few months pass. Then the bleeding changes, or they start to lose weight, or they feel like something just isn't right. And they end up in front of me, and there is a tumor in the colon, and it has been there, growing, bleeding intermittently for over a year. The critical point here is this. A visual external examination of the anus, or even a digital rectal exam or anoscopy, does not tell you what's happening inside the colon. You cannot look at the outside and conclude that the inside is fine. A hemorrhoid and colon cancer can coexist. They are not mutually exclusive, and the only way to actually find out what's inside the colon is with a colonoscopy. And I know there's fear about that procedure. Patients tell me every single day. They're annoyed with the prep. They're scared of the procedure itself. They're scared about what we may find. So let me be direct about what a colonoscopy actually involves. The day before the procedure, you do a bowel prep. You drink a solution that clears out the colon. Yes, you spend that evening in and out of the bathroom. I'm not going to pretend otherwise. It is not a pleasant evening. But look, people sat through a 4-hour Beyonce concert in July heat in full sequins. You can handle one evening at home with a good Netflix show and easy bathroom access. It's one evening. The next day you come in. We give you sedation. You're comfortable. You do not feel the scope at all. From the moment we start to the moment we're done, the actual procedure is somewhere between 10 and 30 minutes. You wake up in recovery, and I'll just say, some of the most entertaining conversations I've ever had in my career have happened in the recovery bay. People say things under sedation that we are professionally obligated not to repeat. But then you have a snack, someone drives you home, and we have a clear answer. And that answer, the vast majority of the time, is good news. I scope thousands of patients every year. Most of them come back with a completely normal colon, or with a small benign polyps that I remove on the spot, or with mild diverticulosis or internal hemorrhoids that we can also address. The answer is most often reassurance. But when we do find something, when there is a polyp that needs to come out, or a mass that needs a biopsy, catching it early is the difference between a surgery that cures someone and a diagnosis that arrives too late. And that difference is why I do this every single day. All right, let me bring all of this together for you. Rectal bleeding is extremely common. The overwhelming majority of the time, it has a completely benign cause. Hemorrhoids, an anal fissure, a small polyp, some inflammation. Most people who see blood are not dealing with anything life-threatening, and I want you to understand that. There is no benefit to panicking every time you see a drop of blood. But the mistake, and I see it constantly, is using that statistical likelihood as a reason not to get evaluated. Because the cases that matter, the cases where the outcome depends on catching something early, those cases can only be identified if people show up, if they make the appointments, if they follow through on the colonoscopy. So here's what I want you to do. If you see rectal bleeding, get it checked out. Do not self-diagnose. Don't spend 3 hours doom scrolling yourself into a spiral. Don't wait another month to see if it goes away. Make an appointment with your doctor. Ask for a referral to a gastroenterologist if you haven't already been properly evaluated. If you are 45 or older and you haven't had a colonoscopy, that conversation needs to happen today, rectal bleeding or not. Your gut is giving you a signal. The right response is to take it seriously and find out what that signal means. If you want more information about the differences between IBS and colon cancer, I will leave that video up here. And if you have any questions or comments, please leave them below. I love reading the comments and responding. And don't forget to subscribe. We have new videos coming out every week, and I don't want you to miss any videos that may be vital for your GI health. I will see you in the next one.